Um, so, what, so what I do is physical medicine and rehab. So in Vietnamese, it's vật lý trị liệu. And what we do is two things. We do outpatient, musculoskeletal. So any joint pain, back pain, muscle pain, sports medicine, pain medicine. So we do that. And in addition to that, we see patients with catastrophic injuries. That's like severe injuries like stroke, brain injury, spinal cord injury, amputation, and things like that. So the goal of physical medicine rehab is to get patient back to highest function. So we may not be able to fix the amputation or fix the brain injury, but we want to work with the patient so that they could achieve independence, they could live alone, they could do a lot of things for themselves. So it takes a lot of patient education, it takes a lot of teamwork in physical medicine and rehab. And it's an old specialty, but not many people know about it. In California, when I applied, there was only 5, and I think there's still only there's only 6 programs in the entire state of California for this. So today I'm going to talk to you about low back pain, which is very, very common. We get a lot of referral for low back pain. And so we'll go over what you could do. All right, so before we start, let's go over the basics. So what is a muscle strain? So muscle strain is a muscle that is overworked, overstretched, or working too much that it's not used to. So for example, if you lift too much weight, then your muscle can't handle that weight. It becomes injured. It's a muscle strain. A sprain usually refers to a tear of the ligaments, like the ligament that's holding your joints together in your elbow, your back, your ankle. Those tear of those ligaments are called a sprain. And then I want to introduce a concept that not many people know about, which is myofascial pain. This is the pain that affects the muscle and the connective tissue, the tissue that connects the muscles together. We call it fascia. And this myofascial pain is very unique because it's associated with trigger points. This can happen to anyone. And then there's a difference between referred pain, radiating pain, and radicular pain. So referred pain is pain that is felt at a site different from the site of injury. So we look at this diagram, referred pain, when we have a heart attack, sometimes the pain, this is in, it's in yellow here, goes to your, goes to your shoulder and your jaw, right? So when you have stomach pain or pancreatitis, sometimes the pain is felt in the back. So those are referred pain. But radiating pain is that pain that spreads to the distal site. So if you have a small pain and then you didn't treat it and it spread, so you may have one point of pain and then the entire muscle now hurts. So the pain appears to spread away from the center. It's radiating, or it goes down the leg, the buttock area. That's radiating pain. And radicular pain is usually a pain that follows the nerve distribution. If you have, let's say, a sciatic nerve that gets pinched, or a nerve that gets pinched in the lumbar area, the pain feels shooting down your leg. That's what we call a radicular pain. All right, so let's a little bit more basics. So in order for us to walk and function, we have to have muscle balance. It is essential for movement. So one of the most important muscles to work out, so many people work out on their chest and their arms. Not many people work on their back, despite it being one of the most important muscles, because it is required to hold us up. If there are muscle imbalance, meaning if your muscle is too weak or you do too much work, then you overwork the muscle, it gets stressed, it gets injured, and you have pain, right? So you look at this picture, once we get older, we usually gain weight, right? And on top of that, you have muscle loss. After 30 is when you start having muscle loss, rate of usually 1% or 4 to 6 pounds a decade if you don't exercise. So after 30, if you don't exercise, we tend to gain weight, we have less muscle. What happens when you have more weight and less muscle, the muscle is not equipped to deal with that extra weight and it's weaker. So what's going to happen is gravity pulls and your spine starts to curve. And then you have like osteoporosis and things like that too. Degenerative disc disease. So you get shorter and you have bad posture, and many people have neck pain and back pain. Then this is why we have stoop posture. Now, with stoop posture is also due to weak extensor muscle. We need muscles right here to hold us up. If you don't have enough muscle, nothing's holding you up, you're going to be stooping, right? The other concept is degenerative disc disease. After 30, we have degenerative disc disease. It does not mean that you have pain. It is aging. It's not a disease, it's a condition. It's a misnomer. We call it a disease, but it's a condition. And it occurs in everyone. So you look at here, you have a very, this is a drawing, this is an MRI. You have a very wet disc, right? And then as we age, the disc gets pretty dry, right? So and then there's more pressure on the bone. And because the disc gets flatter and not as fluffy, what happens is your ligaments holding your back gets very lax, it gets loose, and it allows for movement when you move your back. And when you have too much movement, there's loss of balance. When there's loss of balance, the muscle contracts to hold you together. And if the muscle is weak, it can't do its job, then you have back pain. Right, so back pain, about 90% of the back pain that we see in our clinic is from either muscle strain, from myofascial pain with trigger points, from sacroiliac joint dysfunction, or from radiculopathy. These are very common. Most of you guys have already experienced or are familiar with muscle strain. You may already have it yourself. So in one's lifetime, muscle strain, most people will get muscle strain sooner or later, usually during the later years. And so we're only going to talk about 4 conditions. And the goal for today is for you to explain these conditions to your patient, explain why they have back pain, and kind of go over the treatment and go over some of the exercises. All right, and I will go over it with you now. So when you go to breakup room, you will do it yourself. All right, so we only have 4 conditions, so bear with me. We're going to talk first about muscle strain. Right now, keep in mind that if you have trigger point present, you have sacroiliac joint dysfunction or radiculopathy, you may also have muscle strain because your muscle is trying to hold your back up and trying to compensate. Okay, so we talked about muscle strain already. It is a muscle that's overworked. This is how you explain to a patient. They ask, why do I have this, right? The muscle is working too much. It is too weak to perform a task like lifting or something that's repetitive, like multiple lifting or multiple twisting, painting something, and it gets injured. And when it works too much, excessive work leads to injury or micro tearing of the muscle fibers. And then it's supposed to heal. But if you don't let it heal and you don't work it, then you get more injury. And with more injury, right, the muscles scar down and it gets shorter. And there is no medication that is going to stretch out the muscle except for you stretching it out. So people like to take medications for chronic muscle strain. Muscle is not going to be stretched without any medication, right? So if you just give medication alone, patient is going to come back with pain. You haven't fixed the problem, right? And pain due to muscle strain is the most common cause of low back pain. Right? If you don't even lift, why do you have pain? Well, it could be repeated posture. It could be increased repetitive stress. You have a baby, now you're carrying your baby, right? Or you're carrying a backpack that's too heavy, or you have a big purse that you're carrying on one shoulder, or you have an injury, a car accident, a fall. All these can cause injury to the muscle. Posture is very important because you can do all sorts of exercise, but if all day you walk differently, you're going to cause strain. Normally, this is, you have a lordosis curve here, lordosis curve in your cervical and lumbar area, and a kyphosis curve here. If you don't have good back muscles, what's going to happen is you tend to slouch, right? So you exaggerate the kyphotic curve, but you want to look ahead. So what's going to happen is your head's going to have to move up. And now, what's going to happen is now your center of gravity is forward. That means that this muscle here has to work a lot harder to hold your neck up. And because the balance is off, your back also has to work harder. And overall, because of your street posture, there's loss of height. With age, this gets worse because gravity pulls this way, right? Your back muscles are constantly fighting gravity. So it's essential to keep this up. Lifting is the other way, right? If we don't lift correctly, the muscle has to be very, very strong to pull you upright. So the best way to lift is lift with your legs. Right? Hold this close to you, bend your knee, and push your thigh. You push your thigh up. It's better. Keep your back straight. It's a better way to lift. So even if you don't get older, but you gain weight, right? So what happens is you have a certain muscle mass here, and if people gain weight here, the muscle has to carry more weight. It's like carrying a baby or a backpack in front of you. This muscle will be strained. And as you get older and you don't work out, muscle gets weak. You can expect that this person, the posture is way off, the head is way in the front, the abdomen is here, center of gravity is shifted. So when it's shifted from the middle to the front, the back muscles and the neck muscle has to work harder, and we expect that this person will have pain. So this is what we just talked about to summarize, is if you have an injury from a muscle from long-term or prolonged poor posture, overexertion, overstretching, or overuse, it gets injured. And this is the most common reason for back pain and neck pain. It's correlated with stress, the tension, and continued awkward position. If you have stress, you are also tensing. So the muscle never gets to relax, right? You have poor posture, workplace that requires you to stoop and bend and twist. Or if you just twist real quick, you overstretch, that could cause you pain. Now, when you injure a muscle, right, you have to heal. So when you injure a muscle by activating or stressing it to maintain a certain position, and there's not enough time to heal in between, the healing lacks behind the injury, you have muscle strain. So we all work out, right? You work out your biceps, you want your bicep, your shoulder to be strong. You want it to injure a little bit so you can activate the satellite cells to heal, right? But if you don't do that, you're going to get chronic strain. And so that's why people who work out on their muscles, they don't work out every day. They alternate the days because they want time in between the muscle to heal. And so that's the same thing with your paraspinal muscles. It is very important because if you don't let it heal and it contracts and work all the time, it gets shorter, then you lose your curvature, and then, then it just spirals, right? And then the muscle, when you have pain, the muscle works even more. The more it works, it has pain. This condition, bracing, using to protect the back, is also seen in disc herniation, cervical instability, degenerative disease, or any chronic stress, anxiety, because people with chronic stress, they are tense all the time and they're contracting the muscle all the time. So what do we do? Well, on physical exam, you'll see patients with reduced range of motion. They can't bend their back very long. They have pain over the muscles surrounding the spine or the paraspinal muscles. You could actually put pressure on and feel for the muscle, and you could see the tightness of the muscle. And with muscle strain, there should be no neurological symptoms. Reflexes, sensation, muscle should be perfectly normal. And often people ask, do I really, can I get an X-ray? Do I need an MRI because I feel like something is going on? And here in where I practice, we discourage imaging because imaging is not helpful in the diagnosis of muscle strain if there's no history of trauma, no neurological deficits, or any other associated symptoms. So you would tell your patient that you would validate this muscle strain is very painful, but for your exam, I don't see any nerve issues. And so, and radiation may not be indicated, and it doesn't help us manage your condition better. Right. The other issue is if you do get imaging and the patient is older, by older, I mean over 30, you start degenerating your spine after 30. So if you get an imaging and you get degenerative disc disease, because it's expected with age, patient gets, it's upset, right? Because it's not normal. And reality is when you get older, you don't have a normal spine. But degenerative disc disease, you could have like reduced disc space, osteophytes here. You can see these things. It doesn't mean that that's caused pain. And there's a huge landmark studies by Bowden that if you take x-rays and MRI of people as they age, with the people without pain, they have disc disease, they have arthritis, they may not have pain. So degenerative disease does not mean that they have pain. Now, if the patient has any injury or trauma, or you're concerned for fracture, or patient has cancer, you're concerned about infection, this is the time that you would get imaging. How do we treat? Good ergonomics and good posture, good form when you're lifting. You could treat with Tylenol, acetaminophen, NSAIDs, maybe topical Salonpas, Bengay, we have it here for pain relief. But these things are just for pain relief. You haven't treated condition. Ice is helpful for the first few days. If you have repetitive strain or poor posture, then you really have to ice every day, right? Because every day you're adding new injury. Sometimes a back brace, people love wearing back brace. We only recommend 1 to 2 days. 1 to 2 days only because if you wear longer than that, your muscle gets weaker and then you can't really walk without the brace, right? Heat may be helpful, usually right after the injury or people stiff it. I only do this in the morning. Once people walk around, it's already heated. So if you use anything, it's usually ice. So heat right before stretching or when they first get up, otherwise it's ice. And then a good strengthening and stretching program. If strain is because of a repetitive process, of course you do ice. And then for individual who are obese, weight loss is very important. We also use complementary or alternative medicine, but remember it's for pain relief. You still need to stretch and strengthen the muscle. People ask, I am so much pain, I cannot exercise. Well, by exercise, we don't mean, running, jumping, kicking, jumping rope. There's several types of exercise: aerobic, stretching, strengthening, balance, relaxation. So you need to strengthen and you need to stretch, and you can do aerobic. But for people with low back pain, swimming, bicycling is preferred because you're not loading the back. And then you need maybe these exercises that's no loading the back. It's on floor, they're floor exercises. And you can also do stretching. This is the stretching exercises. If you have to teach a patient, I wrote it here, but you can say in your own word. You have the patient lie. You tell patients to lie on their back with their knees bent and feet resting on the floor. Using their hand, you can slowly pull the knees toward the chest until they feel a gentle stretch. They actually want to keep it for like about 30 to 60 seconds. And then they want to make sure that keep their back relaxed. This is similar, but you have lying your back, legs straight, arms to the side, and then you bring your knee toward the chest and then lower it to one side. So you basically, you're moving it to one side. And you want to hold. And you should feel a stretch of the low back and hip. And then you want to make sure that your body's on the floor and you're not arching up. These are strengthening exercises for the back. You kneel. Stay on all four with your arms positioned directly under your shoulder, and then you straighten out one arm and the opposite leg at the same time. It's like a Superman fly until they're parallel to the floor. And you hold briefly, and then you return to starting position, and then you do the other side. While you're doing this, keep your abdomen tight and hips level. So you don't want to tilt during the exercise. This is another way. Now, there's many, many ways. You can use any exercises, but this is one of them. Lie your back with a wall above your head, knees bent, and feet resting on the floor. And then what you do is you rest your hand against the wall and apply gentle pressure. You want to activate it. You want to activate your abdomen. And you raise one leg off the ground, keeping your knee bent, and you follow. So it's like almost like a bug. You hold and then you lower it, right? So in order to do that, you have to work on your abdomen. This is why it's a good abdomen exercise. And you want to keep your abdominal muscles tight, keep your back flat against the floor during the exercise. All right, so this is a summary of that. Moving on to myofascial pain. So I have about 2 more minutes. We'll go do this a little bit quicker. So I want to introduce myofascial pain because myofascial pain is associated with trigger points. And what this is when the muscle is left untreated, you develop myofascial pain with trigger points, which could occur in any muscles. But since we are talking about the back, we'll focus on the back. Remember, we talked about muscle spasm. If the spasm is continuous, that spasm is going to become very tight, become taut bands. They kind of clump up and become a trigger location or a trigger point. If you press or irritate the trigger point here, pain is going to felt shooting down, usually shooting down the back, the buttock, the leg. This can be confused with a nerve pain. But in this condition, there is no neurological deficit. There's no weakness, there's no tingling, numbness, or reflexes changes. It's seen in trigger point. This is seen in myofascial pain syndrome, right? Myofascial pain has trigger points. And this you could read on, but what it is, again, if you get chronically injured, these actin and myosin become sticky. They kind of stuck, and now they become a knot, and then now the muscle doesn't like it. So it generates a pain response. And what happened with the pain response is the muscle contracts with pain and making the condition worse. So anytime that you activate or you irritate these nodules or these trigger points, the pain shoots or radiates to a distal point. And usually we map it out, and usually trigger points in the low back is here, trigger points in abdomen goes down to the thigh. Most of the pain you'll see, it goes down the thigh, and sometimes it shoots all the way past the knee. So remember, if you shoot past the knee, mimics the radiculopathy or nerve fissure. Right, and so again, they're associated with palpable taut bands, and a nodule over the affected muscles. It occurs locally, and pain occurs locally and radiates distally in a very predictable pattern. And don't confuse it with radiculopathy, which is actual nerve compression. And so how we treat it is, again, good posture, frequent stretching, icing. Because when a muscle is tight, the only thing you can really do is stretch it out. But when a patient has too much pain, sometimes a massage helps because it brings in blood to the area. Correction of the posture helps. Sometimes we put a needle in that point to release the band, to relax the muscle, and then the patient could relax. I mean, could do stretching because it's less painful. You could have NSAIDs to help. Lifestyle changes is very important, just like you do with muscle strain. You want to prevent it. All right. So moving on to sacroiliac joint dysfunction, which is not a condition that most people are aware of, because most people don't realize that pain could actually come from sacroiliac joint. Okay, so sacroiliac joint has very limited motion, but as you know, in women, we have relaxin, right? And it's holding on to this, and it relaxing releases, and the ligaments just relax, right? So what the joint is the reason you have pain there is because there's a whole bunch of ligaments. It's held together by sacroiliac ligament. It gets weaker with trauma or during relaxant release. When you have sudden twist, bending of the back, like you fell, you jumped, this could tweak the joint, overstretched it a little bit, causes more movement. And then what's going to happen is patients will have pain in this area that can refer to the buttock area or the thigh, or even in the front to the groin area. So this is not the same as sacroiliitis, right? Sacroiliitis is a rheumatological disorder where you see an ankylosing spondylitis. This is not the same. This is a musculoskeletal strain and sprain of the muscle. It just happens to be in this joint, and it could be seen in any individual. So this happened to me when I was skiing. I made a jump, and then it tweaked this. I landed wrong, and it tweaked this joint, and I woke up with so much spasm I could not get out of bed. So this is actually very common among the athletes. So there's local pain over bilateral ligament area, right over here, right? Very specific. They have muscle spasm and they have pain here, but a lot more pain over the sacroiliac area. Pain could also refer to the buttock, even the thigh, the paraspinal, quadratus lumborum, and maybe into the front. And when you do provocative testing, when they cross, this is when they have the patient lie supine, you cross their leg, you press down here, we call it Faber because it's hip flexion, hip abduction, and external rotation. So we call it Faber's test. This, when you do this, it hurts one of these two areas. And of course, you get muscle spasm with this. How you differentiate this is that there is no neurological deficits. It's a musculoskeletal thing. There's no other issue with it. And the back and pelvis x-rays are often normal. So treatment includes reduced inflammation, regular icing to the SI area, NSAIDs, the same thing you do for low back pain. Now, if you don't want it to come back, you have to increase pelvic stability. A little bit different. You have to strengthen the gluteal muscles, so the buttock muscles, right? The back muscles and the buttock muscles. You can use pelvic belt like this, right? It helps stabilize the area. Or you can inject into the SI ligament area. And you have to tell the patient, don't cross a leg because this is like Faber's, right? FA, flexion, abduction, external rotation. That will cause pain there. Okay. So last but not least, we're going to talk about radiculopathy, which is nerve pinching as it goes through the neuroforamen and supplies your leg. So the most common cause of radiculopathy is likely a disc or osteophytes or osteoarthritis. And then when the nerve comes out, it gets pinched. So when the nerve becomes pinched, it's damaged, you get abnormal sensation. That occurs along the pathway of the nerve in a dermatomal pattern. Weakness could also occur in the muscles of the nerve supply. Look at the MRI. This is the MRI sagittal view. This is the disc. This is T2 where CSF is white. There's nerve roots that you can see here. And you can see that if, the disc bulging, as long as it doesn't touch the nerve, okay, patients usually don't have any symptoms. But when it starts touching, when it herniates and it starts touching a nerve root here, or you can see in the axial view, when it starts touching nerve root, then people have nerve pain. And not only do you have back pain, but they also have pain symptoms in the area that the nerve root supplies. And usually it's down the leg, right? So they have leg pain with symptoms in back pain with symptoms in the leg, and it could be spasm, tingling, numbness, weakness. And we learned that nerve pain is tingling and shooting, electrical, but it's not always like that. The radiculopathy could just feel like it's cramps. It could feel like strange, like a muscle spasm. So that could also be nerve pain. Usually it follows a specific dermatomal pattern. So if L5 in blue here, pain is usually in the L5, numbness, sensory loss, also noticed in L5. Pain is not reproducible with palpation of the leg. That's how you know it's nerve pain. So if they say pain in the thigh area, you go and you press on this area. Right now, my pain is here. You press on there, it does not reproduce the pain. They just feel the pain there. What reproduces the pain maybe is straight leg raise. So you have the patient lie supine, you have the knee straight, and you lift. And then when that happens, patient will say, "Oh, when you do that, I have calf pain. I have numbness, tingling in my leg." That's a positive straight leg raise. Right? If you do that and they hurt their back, it's not a positive. It has to be some kind of nerve symptoms in the leg. And if the symptoms progressive, you may have leg weakness, muscle atrophy, bowel bladder incontinence. If this is the condition, then we really want the patient to be seen as soon as possible, emergently. You need the MRI to determine the reason for weakness so you can treat it. So in patients with nerve pain, neurological deficits, abnormal sensation, that is confirmed by a physical exam, then we usually recommend an MRI. And to treat it, It's the same thing with treat back pain, very similar. All those back condition is a healthy weight and good posture. Same with NSAIDs, but because there's nerve pain, we use antidepressants, anti-seizure medications for the neuropathic pain. What about therapy? If they have a lot of pain, then lying on your back 2 days will help pressure on the roots. Not more than 2 days, because after that, you get weak. So 2 days, and then after that, they should learn proper posture, body mechanics, lifting. You don't want them to sit too long, because sitting in radiculopathy could cause more pain than standing. So avoid prolonged sitting, avoid lifting and stooping. And when the symptoms have improved, definitely need to strengthen the back and the abdomen muscles. And if they're obese, then weight loss. We can also do epidural injections with corticosteroids in that area to reduce inflammation. In severe cases, surgical excision of that disc or osteophytes or laminectomy may be helpful. Right, so to summarize, it's a condition that results from compression to the spinal nerve, usually due to the disc or to osteophytes. It's very common in the cervical and lumbar area, not so common in the thoracic, even though it could occur there. And usually it occurs with abnormal sensation, which is like tingling, numbness, and pain that radiates from the limb to the neck, or radiates from to the limb from the neck or back, and they may be associated with muscle weakness. And if you have bowel bladder incontinence, that is urgent. All right, so just to summarize, if the pain due to muscle strain, that's overworked. You have local pain, worse with movement, activities, usually spasm, no neurological deficits. If there are trigger points, there's usually a taut band, and if you press on any of these points or stretch any of the points, the pain reproduces, it shoots, right? You don't get that in nerve pain, you get it at trigger points. Push on this, and the patient said, oh, I feel it in my back, or I feel it in my leg, I feel my toes, or my calf. So pain is reproducible, no neurological deficits. If you have SI joint dysfunction, the pain is right over the SI. They may have muscle spasm, but explicit pain is over here. And when you press on this, they may have referred pain, not radical pain. They think, so when you press on this, they may have, oh, I think my pain in the buttock is a little worse. You have them do favors, and it gets worse. And they say, yeah, it's worse when I cross my legs. Again, this has no neurological deficits. And the only one with neurological deficits in these 4 conditions is radiculopathy, where you have pain shooting, sensory or motor abnormality, and then this is when you really need an MRI to show the etiology of nerve compression. All right, so I am a little bit over, but hopefully you are ready for your interactive sessions. What you are going to be doing there's 5 cases, right? You are going to interview the patient, which is the TA. You're going to ask the history, and the TA will just give you the history. And then after that, you can ask them for what's the finding of the physical exam. They'll show you what the physical exam is. So you don't have to do a physical exam, hard to do online. And then for case 1, you're going to counsel the patient, why imaging is not indicated. Each case is a little bit different, but most of it is patient education, is talking to patient, explaining why they have this condition, explaining how to do the exercises, and explaining maybe the treatment plan and things like that. All right. Stop sharing. Does anybody have any questions? Or are you totally confused? Too many questions. All right.
Thank you, Dr. Fan, for Hello, guys. So you ready to conquer low back pain, become the master of low back pain? Go ahead and go to your room, and we will.
I have to tell them the room.
Okay, Dr. Helen Tran, please.
Okay, thank you. Okay. Just a reminder. So as Dr. Guenzao was saying, in the breakout rooms, we will have